Good evening, everyone. So today the class is on perioperative anaphylaxis, which is again a clinical topic which is important in our day-to-day practice, as this would be one of the differential diagnoses for any tachycardia or bradycardia, which is associated with hypotension, and the diagnosis of it may often be delayed because of the concomitant anesthetic factors which are involved. So I'm Dr. Gurusanthiya, who will be telling about in nutshell about the perioperative anaphylaxis or intraoperative anaphylaxis today. So, why is the topic more important is it is associated with life-threatening catastrophe, and it can be just a second. So it is associated with life-threatening catastrophe wherein the morbidity and mortality can be as high, and the mortality can be somewhere around 1 to 4%. And the incidence has always been varying depending upon patient to patient and country to country characteristics, wherein the incidence can vary up to 1 is to 3 to 1 is to 18,000 anesthetics which are administered. And the identification is often difficult because of the multifactorial etiology which would be there when you are anesthetizing the patient, as in you would administer somewhere around 4 to 8 drugs when you are inducing a patient. All these drugs can be an inciting factor. The patient might have been a patient who is in sepsis. So any tachycardia and hypotension which would occur would be attributed to sepsis rather than anaphylaxis. You would have administered thiopental. The patient can have tachycardia and hypotension. You may think that it is because of vasodilatation and the thiopental, which is increasing the heart rate, and the patient is volume depleted, and hence heart rate is increased. So you would, before even you could think anaphylaxis as a differential diagnosis, the patient could be in the verge of sinking because of the anaphylaxis reaction which is happening to the patient. So the identification in the perioperative setting is very, very difficult. Suppose if it happens in the ward, you give them coamoxiclav, and if they are hypotensive and having angioedema and urticaria, there is no diagnosis which would explain that it is an anaphylaxis reaction rather than anything. But in anesthesia, it is always difficult to identify and treat early if the anaphylaxis is happening. So these anaphylaxis reactions are usually hypersensitivity reactions. The pathophysiology can either be allergic mediated or non-allergic mediated. Depending upon how fast the patient presents, it can be classified as immediate, which occurs within 1 to 6 hours, or delayed, which occurs within days to weeks after inciting factor which is incited to the patient. The term of anaphylactoid reaction is no more used across Europe, and it is not prudent to use also. You can either use as allergic mediated hypersensitivity or anaphylaxis reaction, or non-allergic mediated. You can term as either immediate or delayed. And the pathophysiology, as I mentioned, it is either allergic or non-allergic. And the allergic mediated mechanisms include the binding of antigen to the high affinity FcRI receptor. The phase of sensitization in case of allergic mediated reaction is usually silent. And whenever there is re-exposure to a particular antigen, two antigen will cross-link and bind these IgE to the Fc component of receptor. This will result in signal transduction and lead to mast cell and basophil activation, which will lead to degranulation and release of already preformed histamine and leukotrienes, or newly formed leukotrienes and inflammatory mediators and thromboxane A2, and also all the inflammatory mediators. So this is basically because of mast cell degranulation, and it is because of the IgE the antigen which cross-links to IgE to the FcI receptors. There is also another mechanism by which these mast cells can be activated. It can be either a direct activation, or it can be because of a calcium mediated activation, or it can be because of the mast cell MGR-PRX2 receptor, which can also lead to mast cell activation. So these allergic mediated response I have discussed early, and these non-allergic mediated response can be because of mast cell activation or mast cell independent mechanisms. So these mast cell activations can be either direct non-specific activation, as in histamine releasing agent, which is usually mild, or moderate, and it is an immediate reaction. These type of reactions would happen to drugs such as mivacurium, atracurium, or propofol, and calcium and phospholipase mediated dependent mechanisms wherein it can lead to vancomycin related Redman syndrome. And another mechanism is MRGP or X2 activation, whereas it is the neuromuscular blocking drugs related mechanism. And another is a mastocytosis, which is a clonal disorder which can happen and manifest as cutaneous reactions like erythema hives in case of cutaneous mastocytosis in pediatric age groups, or a systemic mastocytosis which results in unexplained anaphylaxis reaction in a elderly or an adult patient. These muscle independent mechanisms are the COX-1 inhibition NSAIDs, like which can happen in case of NSAIDs, which can lead to bronchospasm or angioedema. There are also factors that will modulate the onset of allergic and non-allergic mediated hypersensitivity reaction, which include stress, infection, dose of allergen, rate of administration of the drug, the chemical property and molecular weight of a drug, and the host factors. So all these will determine how the patient is going to respond to a allergic mediated response. Suppose if the patient has got a sepsis, and whenever you induce a patient for a above knee amputation, the patient cannot be given a regional. You have induced the patient with rocuronium. The patient is already septic. The patient has allergy to rocuronium. Then the patient has sepsis. The patient is again volume depleted. When you give rocuronium and anaphylaxis, the patient is again going to be extremely volume depleted. So these are the things which will affect the patient whenever you're given in a perioperative setting. Your anesthetic agent will also modify the response, how the patient is going to respond. The host factors also will determine how the patient is going to respond, and how fast you inject the drug. How sensitized is the patient previously to the particular drug also will determine how your patient is going to respond for a particular drug, which is the offending drug. And the clinical presentation can vary, and it usually, if it is an allergic mediated or non-allergic mediated immediate reaction, it would occur within minutes. If you would give the inciting agent as an IV drug administration, then definitely you're expecting the reaction within minutes. Based upon the severity and timing of administration and how allergic potential that the drug has got, the manifestation can either be cutaneous manifestation as in hives, itching, or it can lead to bronchospasm, or the patient can have tachycardia, hypotension, or cardiovascular collapse. So non-IV administration of drugs such as patent blue drug, which is given for the sentinel node identification in case of CA, breast or such, so then you're giving it as a non-IV administration. Then the onset of anaphylaxis can be delayed as much of 30 minutes to 1 hour, because it has to get absorbed in the system and then incite a anaphylaxis reaction. So these are the drugs, or these are the mechanisms by which you will commonly miss anaphylaxis as a diagnosis of the hypotension and tachycardia which the patient would otherwise get. So clinically and like for the purpose of classifying these anaphylaxis, there has been a grade which is a Ring and Messmer grading, wherein it is classified into 4 grades, where you get the grade 1 is cutaneous signs, which is characterized by generalized erythema or extensive urticaria. Grade 2 is moderate multivisceral involvement, moderate hypotension, tachycardia with and without a bronchospasm or GI symptoms. And grade 3 can be life-threatening monovisceral. Either the monovisceral can either be refractory bronchospasm or refractory hypotension, or a multivisceral which would involve cutaneous bronchospasm and cardiac, or life-threatening hypotension, tachycardia with bronchospasm, and cutaneous signs may be absent before hemodynamic stability. Suppose if the patient, once you have given an inciting agent, the patient became extremely hypotensive, then you may not see cutaneous manifestation. Since because you did not see a cutaneous manifestation of erythema or swelling of lips or angioedema, you need not think that it is not anaphylaxis, because the patient is so much so hypotensive that the cutaneous perfusion itself is lost. Once when you restore cutaneous perfusion with your drugs and IV fluids, then the patient may start showing cutaneous manifestations. So if the cutaneous manifestation is not there, it doesn't mean that the patient is not having anaphylaxis. It just means the patient is so hypotensive that there is no cutaneous perfusion at all to have a cutaneous manifestation.